Late-Onset Tay-Sachs Disease, LATES, is an autosomal recessive inherited inborn error of metabolism, IEM, caused by mutations in the HexA gene, leading to a deficiency of Hexosaminidase A, which causes the accumulation of GEM2 ganglioside in the brain. This accumulation damages nerve cells and affects motor, language, and cognitive functions. LOTS symptoms are often confused with mental health issues and may be misdiagnosed as stuttering, ADHD, or psychiatric disorders. The onset of the disease can range from late adolescence to adulthood, and there is significant variability in symptoms even among family members. The neuropsychiatric symptoms of LOTS are associated with damage to several brain regions, especially the cerebellum, frontal lobes, basal ganglia, cortex, and limbic system, which are responsible for motor coordination, emotional regulation, cognition, and behavior control. In the cerebellum, Purkinje cells cannot clear toxins due to the lack of HexA, leading to motor coordination problems and speech disorders. Frontal lobe damage impairs higher cognitive functions like decision-making, emotional regulation, and social behavior, resulting in mood swings, cognitive decline, and psychiatric symptoms. The interaction between the cerebellum and frontal lobes worsens symptoms, severely affecting the patient's quality of life. Diversity of LOTS. Symptoms. The initial symptoms of LOTS may include progressive muscle weakness, atrophy, ataxia, and acute psychiatric symptoms. As the disease progresses, muscle spasms, cramps, and weakness worsen, initially affecting the quadriceps and hip flexors, requiring walking aids. Patients may develop tremors, dysarthria, and dysphagia. Acute psychiatric symptoms, such as mania and depression, may require psychiatric treatment. As the disease advances, cognitive impairments, including executive function and memory deficits, may gradually appear. An article from rarediseases.org shows the diversity of LOTS symptoms. The researchers conducted a literature review of neuropsychiatric symptoms in patients with LOTS by searching databases. Case 1. From mental health issues to genetic diagnosis. LOTS is a genetic neurological disease that usually presents with symptoms in late adolescence or early adulthood. However, many patients' first symptoms are psychiatric, such as mood swings, mania, and speech disorders, leading to misdiagnosis. An article from DOI reports a 36-year-old Irish male patient who first showed symptoms at 17, including psychomotor agitation, inability to stay still, expressed as anxiety and irritability, mood swings, manic-like symptoms, hypersexuality, and speech disorders, slurred speech. He was diagnosed with affective psychosis, ADHD, and Asperger's syndrome. At 17, a CT scan following a fall revealed asymmetry in the temporal horns, raising suspicions of medial temporal sclerosis, but further tests showed no brain damage. At 31, after his brother was diagnosed with LOTS, genetic testing confirmed the diagnosis. Although no specific treatment exists, early diagnosis can help alleviate symptoms, improve quality of life, and provide time for potential future breakthroughs in treatment. Case 2, a 14-year-old patient. This patient first developed speech issues at 4 years old with unclear pronunciation and began speech therapy. At 5, family members noticed he was thinner than his peers and had poor motor abilities, with examination revealing uncoordinated gait, hypotonia, and hyperreflexia. CT and MRI showed no significant brain abnormalities. Between the ages of 11 and 13, he developed dysphagia and drooling, and MRI showed mild cerebellar degeneration, though metabolic tests were normal. At 14, psychiatric symptoms such as anxiety, paranoia, isolation, reduced appetite, and decreased sleep appeared, accompanied by odd speech and gradually worsening symptoms. Eventually, he could not speak, avoided communication, and became fully withdrawn, requiring hospitalization. With early speech and motor development issues, he was diagnosed with LOTS. Although his psychiatric symptoms appeared at 14, the early signs of language and motor developmental issues suggested a neurological disorder. Although no cure exists, supportive treatments and medication can alleviate symptoms. Initially, the patient's brief psychiatric issues were partially managed with high doses of lorazepam and risperidone. However, antipsychotic drugs have limited effectiveness for LOTS, especially chlorpromazine and tricyclic antidepressants, which may worsen the condition. Early diagnosis is crucial for more effective treatment. Case 3. LOTS in an Irish family. In a case from a non-consanguineous family with 10 children, several siblings were diagnosed with LOTS. 2.4. Proband. A 56-year-old male with a 10-year history of progressive dysarthria, gait ataxia, and diffuse muscle atrophy. He had mild learning disabilities in childhood and later developed aggressive behaviors, alcoholism, and incontinence. Initially diagnosed with spinocerebellar ataxia and mild intellectual disability, an examination at 52 showed widespread muscle atrophy, hyperactivity, pyramidal and cerebellar signs, and mild cognitive impairment. MRI showed pronounced cerebellar atrophy. 2.5. A 54-year-old female who developed progressive dysarthria and ataxia in her early 20s, along with a history of mild learning disabilities, bipolar disorder, epilepsy, frequent lower respiratory infections, and incontinence. Over time, her mobility declined and she became dependent on walking aids. Her cognitive and behavioral abilities also declined, and she has been in a care facility since her late 40s. Examination revealed frontal lobe signs, axial dystonia, cerebellar signs, and ataxic gait. The mini mental state examination and frontal lobe assessment scale scores are combined with Brodmann's area analysis. The frontal lobe is located at the front of the brain's cortex and is involved in higher cognitive functions such as planning, decision-making, inhibitory control, attention, emotional regulation, and social behavior. Brodmann areas 9 and 10, prefrontal cortex, are associated with executive functions, goal-directed behavior, planning, and decision-making. The patient's frontal lobe dysfunction is manifested by poor attention, reduced language fluency, and impaired impulse control, as reflected in cognitive assessments such as attention 0 out of 5, language 6 out of 8, and copying 0/1. Damage to this area makes it difficult for the patient to perform complex tasks, lacking proper decision-making abilities and the capacity to adjust behavior effectively. Brodmann area 11, medial prefrontal cortex, is related to emotional regulation and social behavior control. Changes in the patient's emotions and behaviors, such as bipolar disorder, may be associated with dysfunction in this area. Damage to the medial prefrontal cortex can lead to mood swings and difficulty in social interactions, explaining her symptoms of mania and behavioral issues. Brodmann, area 46, dorsolateral prefrontal cortex. This area is closely associated with working memory and task regulation. The patient's impairments in working memory and executive functions, as indicated by their cognitive scores, support the possibility of damage to this area. Brodmann area 6, cerebellar motor area. The cerebellum's functions include not only balance and motor control, but also fine motor control and coordination. Cerebellar atrophy may lead to motor incoordination and ataxia, with patients exhibiting unsteady gait and uncoordinated movements, which are consistent with cerebellar dysfunction. Through Brodmann area analysis, we can better understand how the patient's frontal lobe dysfunction and cerebellar atrophy affect motor, cognitive, and psychiatric symptoms. Cognitive impairment and behavioral issues are linked to frontal lobe damage, while motor and coordination problems are directly related to cerebellar atrophy. The combined dysfunction of the frontal lobe and cerebellum leads to the patient's diverse degenerative symptoms. Second 6. The sixth child of the family, this woman dropped out of high school at the age of 16 due to mild learning disabilities and started working until she developed severe depression. At 19, she was diagnosed with schizophrenia and was hospitalized in a psychiatric facility for 8 years. She has lived in a nursing home since her early 30s. She has had a long history of speech disorders. In the past 5 years, she developed mild hand clumsiness, ataxia, and hand tremors. Examination revealed emotional blunting, cerebellar signs, and mild cognitive impairment. Second 9. The ninth child of the family. This woman exhibited delayed motor and language development from childhood, learning to walk at age 2 and starting to speak at age 3. At 15, she had a severe psychiatric episode marked by agitation, paranoia, and delusions, and was hospitalized multiple times due to worsening behavior. Her condition gradually worsened, leading to speech disorders, gait ataxia, epilepsy, and cognitive impairment. An MRI of the brain showed cerebellar atrophy. At 36, after an evaluation, genetic metabolic disease, IEM, was suspected, and she was eventually diagnosed with Late-Onset Tay-Sachs Disease, LOTS. She passed away at 41 and had been dependent on a wheelchair for the last 6 years of her life. Second point 1. The first child of the family, this eldest brother, had moderate intellectual disability. He developed behavioral problems in his adolescence, followed by progressive gait ataxia and epilepsy. He required full-time care starting at age 18 and passed away from lung cancer at the age of 51. Several members of this family have been diagnosed with LOTS, showing significant differences in symptom presentation and disease progression, including age of onset, clinical manifestations, and symptom advancement. Early diagnosis is crucial for genetic risk assessment. Through genetic testing, family members can determine whether they are carriers or affected, which allows for more informed reproductive decisions and the prevention of hereditary transmission. Identifying the disease not only aids in patient treatment, but also provides important health information for relatives and future generations.
Confirmed known IEMs. Inborn errors of metabolism, IEMs, are caused by genetic defects in metabolic pathways leading to the accumulation of toxic substances or metabolic abnormalities affecting multiple organ systems, including the nervous, muscular, and cardiovascular systems. Any disease involving enzyme or biochemical pathway defects can be classified as IEM. According to data from 2025, more than 1,564 types of IEM are known, but approximately 40 to 50% of patients remain undiagnosed. Common types of IEM diseases. As of 2025, 275 treatable IEMs have been confirmed, accounting for 18% of known IEMs. The most effective treatments are for fatty acid and ketone metabolism disorders, 67%, followed by vitamin and cofactor metabolism disorders, 60%. The most common treatment strategies are medication and nutritional therapy. Timely detection and diagnosis are crucial, as early treatment can prevent irreversible damage. Even without specific treatments, diagnosis provides prognostic information and genetic counseling. Supportive therapy helps alleviate symptoms, stabilize disease progression, and improve quality of life.
Genetic metabolic brain diseases, GMBDS, are caused by genetic mutations that lead to the loss or dysfunction of metabolic enzymes, disrupting normal metabolic processes and resulting in damage to the nervous system, particularly the brain. These diseases cause the accumulation of metabolic products in the body, especially in the brain, leading to neurodegenerative changes, cognitive decline, and motor disorders. Common metabolic disorders in GMBDS include lysosomal storage diseases, mitochondrial diseases, and lipid metabolism disorders. Early identification and treatment of IEMs are crucial for slowing disease progression and improving mental health. Mechanism of brain damage in LOTS, patients caused by genetic metabolic brain diseases. LOTS is caused by a deficiency of beta-hexosaminidase A, HexA, leading to the accumulation of GM2 ganglioside in the nervous system, particularly in the cerebellum and frontal lobe regions. This accumulation causes the degeneration of nerve cells, especially damage to Purkinje cells, which is a pattern of brain region damage similar to that seen in genetic metabolic brain diseases. Cerebellar function and neurological damage. The V, I, and E, A, and E, B lobules of the cerebellum are responsible for fine motor coordination and balance. GM2 ganglioside accumulates in Purkinje cells in the cerebellum, leading to their dysfunction and death, which in turn causes symptoms such as ataxia, muscle tone disorders, and dysarthria. Accumulation of gangliosides. Purkinje cells in the cerebellum are more reliant on lysosomal degradation of lipids than other nerve cells. The absence of HexA leads to an inability to degrade GM2 ganglioside effectively, resulting in its accumulation within Purkinje cells, causing neuron death and cerebellar atrophy. This is the core mechanism behind the motor disorders seen in LOTS patients. Frontal lobe damage. Frontal lobe damage causes cognitive impairment and behavioral issues, affecting decision-making, emotional regulation, and social behavior control. Symptoms include mood swings, depression, anxiety, mania, cognitive decline, poor decision-making and planning abilities, inattention, and social behavior issues, poor impulse control, abnormal social behavior. Basal ganglia. The basal ganglia, including the caudate nucleus, putamen, and globus pallidus, are involved in the initiation and regulation of movement. Damage to this area can lead to various movement disorders, including hyperkinesia, such as chorea, and bradykinesia. Cerebral cortex. The cortex, including the sensory, motor, and association cortices, is responsible for processing various types of information, including sensory input, motor control, language, and executive functions. The metabolic products accumulated in lots may affect the cortex, leading to widespread cognitive impairment and neuropsychiatric symptoms. Hypothalamus and limbic system. The hypothalamus, amygdala, and hippocampus are part of the limbic system. Damage to these areas is closely linked to emotional and memory issues, and for LOTS patients, emotional and behavioral symptoms are often the most prominent manifestation. In summary, stuttering may be related to cerebellar damage. ADHD, associated with frontal lobe damage affecting attention and impulse control. Speech disorders result from impaired cerebellar coordination and frontal lobe language processing functions. Psychosis, depression, and bipolar disorder are linked to emotional regulation and social behavior issues caused by frontal lobe damage. Frontal lobe damage may also affect social cognition, leading to social difficulties and repetitive behaviors. In lots, frontal lobe damage can cause symptoms similar to Asperger syndrome. Conclusion. Through lots, we demonstrate how genetic metabolic brain diseases can lead to neuropsychiatric symptoms, exploring the metabolic mechanisms underlying mental health disorders. Scientists may discover more unidentified IEM types in the future, helping more patients with mental health issues receive accurate diagnoses and treatments.